Today we are going to learn about periapical abscess. So, periapical abscess is also known as dentoalveolar abscess, alveolar abscess and phoenix abscess. You have to remember all these names because MCQ can arise from this and you may get confused. So, you have to remember that. So, you can see it is developed from, where it is developed from? It is developed from acute periodontitis and periapical granuloma. So when there is acute periodontitis, that is inflammation of PDL, and periapical granuloma has formed, then it is eventually lead to this periapical abscess. It is an acute exacerbation of the chronic lesion. So it is an acute exacerbation of chronic lesion. Next, moving forward to etiology. So you can see in the etiology can be pulp infection, trauma, pulp necrosis, irritation of periapical tissue, that is our endodontic procedures. So these all are the etiology that can lead to this periapical abscess. Now next, moving forward to clinical features. So when we talk about clinical features, so tooth is usually tender. Tooth is tender. The tenderness of the tooth is seen, and which is get relieved after pressure application. There is a extreme painful tooth. The tooth is usually extreme painful because there is a abscess formation, and abscess formation is nothing but lead to pain to the tooth when there is any stimulation to it. Tooth is extruded out of the socket. So the reason is same, because there is a abscess formation has seen in apex, so the tooth is pushed little upward into the oral cavity, so extrusion of socket is seen. Next is radiographic feature. So in radiographic feature, what will we see? There is a slight thickening of pedial space. So there will be a slight thickening of pedial space, and there will be radiolucent area at the apex of the root. So there will be like this radiolucent area at the apex of the root, and there will be thickening of pedial space. So let us see in this picture. Yeah. So you can see in this picture, you can see there is a thickening of this pedial space, and now you can see this radiolucent area is nothing but periapical abscess. So this is the periapical abscess. So next, moving forward to histologic feature. So when we talk about histologic features, so area of suppuration is seen. So area of suppuration seen, which usually contains polymorphonuclear lymphocyte, any other type of lymphocytes, cellular debris, necrotic material and bacterial colonies. So these are usually present in this suppuration, which is that present in this abscess. And there is also dilatation of blood vessel can be seen. Marrow space showing inflammatory infiltrate. So usually inflammatory infiltrate will going to be present. Serous exudate, which is present in the abscess. So now let us see this. Here you can see these all are the abscess. These all are the abscess which is seen in this periapical abscess. Next is treatment. So when we talk about treatment, there will be option that we can drainage of abscess by opening the pulp chamber. So what will we do? We will do root canal treatment. We will remove all the pulp tissue, and then we will do drainage of the abscess and then seal it with proper restorative material. And other option is extraction. So we will remove that tooth from the socket only. Now let us see complication. So if this periapical abscess is left untreated, it can lead to osteomyelitis when it is invaded into the bones, surrounding bone. It can lead to cellulitis, it can lead to bacteremia, and it can also show the formation of fistulous tract by opening into the oral mucosa. So in this fistulous tract, what will we see? There is a drainage present into the oral cavity, like from the gingiva or elsewhere. It is like draining the pus out from the this abscess into the cavity. That is the fistulous tract, and sometimes cavernous sinus thrombosis can also occur.